Hi everyone, and in this video I will be discussing thrombolytics, or what we call as fibrinolytics. Now actually this is the drug which will cut the clot. So we know that if this is an artery or a vein, there is a chance there is a formation of clot. So the clot will block the circulation. So the fibrinolytics are the one which will cut the clot. So where to use this fibrinolytics? We use it in the management of MI. So which MI should I use fibrinolytics? It is used in ST elevation MI. And also we use it in a stroke called ischemic stroke. So we use fibrinolytics in ischemic stroke, and also we use it in pulmonary embolism, and we use it in the deep vein thrombosis, and one more condition is peripheral artery occlusion. So peripheral artery occlusion, these are the conditions where we use it. But how do we cut the clot? Is there anything already present in our body which can cut a clot? Yes, we have something, and that is called plasmin. Now let me take an example. Suppose the clot has to form. The cells are tightly bound by the fibrin. So what I'm writing is the fibrin. Now fibrin has to be cut, and we have a scissor to cut that, and that is called plasmin. So plasmin is the one which will cut that fibrin and releases the clot. So plasmin should be activated. So where do you get plasmin? You will get plasmin from plasminogen. So whatever drugs we use, they are going to convert plasminogen to plasmin, and that will act as a scissor and cut the clot. So it's like you are keeping some food inside and you are tied with a rope, some goods inside and tied the rope. So if you want to clear it up, cut the rope and that will come out. So same thing happens here. Now let us understand the thing here. So plasminogen should be activated to plasmin. So plasmin, I told you, is like a scissor. That's the one which cuts fibrin. And when it cuts the fibrin, there is clot dissolution. So this is what happens naturally. But it takes time. So when we use drugs, the drugs will convert plasminogen to plasmin. So what does fibrinolytics will do? Fibrinolytics, the drugs will convert plasminogen to plasmin. This is enhanced by the fibrinolytics. So other drugs we have. The drugs are streptokinase, and one more drug is called urokinase. So streptokinase is obtained from a bacteria. Urokinase is obtained from human urine, but actually it's not from human urine. It is done with recombinant human kidney cells. I mean, it is from the cell culture. So streptokinase and urokinase, the major drawback of the drugs are allergic manifestation. They can cause allergy. That's why the usage has come down. Second important problem is, now where should we activate plasminogen to plasmin? You should activate at the site of clot. But they will activate plasminogen to plasmin everywhere. So what happens? They will activate plasminogen to plasmin everywhere in the body, not only near the clot, everywhere. So what happens? Plasmin is increased, so that will decrease the fibrin. So when the fibrinogen level decreases, what happens? There is a increased risk of bleeding. So the risk of bleeding is going to be very, very high with these drugs, that is streptokinase and urokinase. So they will activate plasminogen everywhere and deplete the fibrinogen, and the risk of bleeding increases. Since they are producing allergy, if you want to give another dose of the drug to the patient, already the body has antibodies to them, so you have to give more loading dose. So because of this, recently we have come up with certain other drugs which are fibrinolytics. So the newer drugs which are fibrinolytics, and the name is called altiplase. So altiplase is a recombinant one. It's a recombinant tissue plasminogen activator. TPA stands for tissue plasminogen activator. It's a recombinant form. The advantage of that is less risk of bleeding, and it will activate plasminogen, which are bound to fibrin. So where they are bound to fibrin? At the site of clot. So there is a less chance of bleeding. Second, it is inactivated immediately by PAI1. What is PAI1? Plasminogen activator inhibitor 1. It is plasminogen activator inhibitor 1 that will inactivate immediately. That's why the drug is short acting. So since the drug is short acting, I cannot repeat it again and again. So I have to give it like IV infusion. The drug has to be given by IV infusion. Now where to use it? The drug altiplase is used for ST elevation MI. It is used in the ischemic stroke. Then the venous thromboembolism, that is pulmonary embolism and DVT, and also the DVT and pulmonary embolism. These are the two important conditions where we use altiplase. Now later we came with one more fibrinolytic that is called retiplase. Now retiplase is mainly used in MI and it is given as 2 bolus injection. So it is given 2 bolus IV and the bolus should be 30 minutes apart. One more drug is tenecteplase, which is a bit longer acting. Tenecteplase is used for management of MI as well as pulmonary embolism and it is given as single bolus. So these are the fibrinolytics what we use in the therapies. So streptokinase, urokinase are older ones. The problem is allergy and the risk of bleeding is higher. The newer ones are altiplase, which is given as continuous IV infusion, retiplase 2 bolus, and the tenecteplase is given as single bolus. So all these drugs, fibrinolytics, what is the major drawback? We all know that all these drugs, the major drawback is bleeding. Yes. Now let me tell you certain contraindications of fibrinolytics or thrombolytics. Where we should not use fibrinolytics or thrombolytics. Number 1, can we use it in non-ST elevation MI? No. They are contraindicated. Number 2, in the head. So when you think of head, what are the places where you should not use? If the patient had some intracranial hemorrhage, already had a hemorrhage, don't use it because they cause bleeding risk. Second, if they had head trauma, patient had head trauma less than 3 months, or patient had a ischemic stroke less than 3 months. So these conditions you should not use it. The next important is if the BP is not controlled, we call it as uncontrolled hypertension. We don't use it. If the patient has bleeding disorder, that will increase the risk, or the patient has bleeding tendencies, then we should not use it. Then any major surgeries. If the patient has undergone any major surgery, within 3 weeks, you should not use thrombolytics. So these are the major contraindications. Okay, even if they have active GI bleeding or anything else, so you should be very careful. So that is about thrombolytics. Now one more topic I just want to cover in the video is something called anti-fibrinolytics. The name is antifibrinolytics. What are the drugs? The name is called tranexamic acid, and one more is called epsilon amino caproic acid. So in short, we call it as ECA. It is called as ECA. One is tranexamic acid, one is epsilon amino caproic acid. What is their mechanism of action? What do they do? They will not inhibit the conversion of plasminogen to plasmin. So they will bind to plasminogen, they will bind to plasmin. By binding to that, they will not allow them to cut the fibrin. So they will not allow fibrin to be cut. Fibrin is not cut. So when the fibrin is not cut, the clot is stabilized. So they will bind to plasminogen, they will bind to plasmin, and by binding to that, they will not allow fibrin to be cut. And if the fibrin is not cut, clot is stabilized. And if the clot is stabilized, what happens? Bleeding stops. Now tell me which condition you want to stop the bleeding. We have to use antifibrinolytics. Uses. The antifibrinolytics are used, number one, the bleeding conditions such as menorrhagia. Number two, after dental extraction. Then postpartum hemorrhage. And D, very, very important. These are the antidote for fibrinolytic overdose. Suppose if you have given altiplase or retiplase higher dose, some patient has bleeding, then how do you reverse it? Give antifibrinolytics. The name is called tranexamic acid and epsilon amino caproic acid. So that is about the fibrinolytics and antifibrinolytics. Please remember, they activate fibrinolytics, activate plasminogen into plasmin. They all end with ASC. So any drug ending with ASC is an enzyme. So these are all enzymes. So we have streptokinase, urokinase. Older drug, risk of bleeding, allergy is more. Newer drugs are altiplase, retiplase, tenecteplase. So these are mainly used for the MI, the ischemic stroke, pulmonary embolism, DVT, and peripheral arterial occlusion. And coming to the antifibrinolytics, they bind to plasminogen and plasmin. So they don't cut the fibrin. So fibrin will stay, the clot will get stabilized, and the bleeding stops. So this is about antifibrinolytics. And one important thing they will ask you repeatedly in the exam is, what is the antidote for fibrinolytic overdose? It is antifibrinolytics. The name is tranexamic acid and epsilon amino caproic acid. Thank you all.